Stanley Nelson. I'm very pleased to get to introduce a friend and longtime colleague, Dr. Richard Finkel, for our CTSI presentation today. Appreciate him coming from across the middle of the country to here, making time in his schedule to make this happen. He's had a long and storied career. He's currently at St. Jude's Children's Hospital in Memphis, Tennessee, where he holds the St. Jude Endowed Chair in Neurotherapeutics, which I think is quite apt. And he's been there now for a little over 3 years, having moved from Orlando before that at Nemours Children's Hospital, where he was director of the Division of Neuromuscular Diseases. He went to college in Washington and Jefferson College in Washington, Pennsylvania, then went to Washington University School of Medicine. And I think he couldn't get into the University of Washington for your residency. So he was forced to go to Boston Children's Hospital just to break the chain of Washington's. Anyways, he's trained in pediatrics, neurology, neuromuscular disease throughout Boston at Harvard, and then took a position for well over a decade at the University of Colorado in Denver. And after that was a long time at the University of Pennsylvania, where he ran the neuromuscular program there before transitioning to Orlando and then to here. So I've known Dr. Finkel, and the world has known Dr. Finkel as being just an outstanding clinical researcher. So he's actually one of those physicians who has a very warm heart, very thoughtful, but also has that special character of being very data-driven and very no-nonsense in terms of how to interpret data, how to build data, and how to make clinical trials meaningful. And this wasn't the case in the neuromuscular field, sort of as you were emerging into this field. So there's all those parts had to be created, and Dr. Finkel has been an integral part of that. And he's now at the tip of the spear as we move genetic medicine into clinical practice for rare diseases, and particularly for SMA. So his insights over the whole course of this area, and particularly as we're putting in gene replacement therapies into kids and adults ultimately, is very prescient. And it's great to sort of now see your now multi-year experience in this area. So please welcome. You know how to run everything?
Just enter or click. What are we doing here? Okay, so just there you go. Go through. There you go. We're good. All right. So, well, thanks, Dr. Nelson. It's indeed a pleasure to be here, and I welcome those also online. I'm going to present a few things from a clinical perspective, but try to focus on what have we been learning about these diseases as we treat them, and what are some of the challenges that we're dealing with. These are my disclosures. And I will be discussing some off-label and investigational use of several drugs. Let me know if I need to speak up if you can't hear me, either here in the room or online. So I'm going to review some gene-directed therapies. I'm going to give you the example of spinal muscular atrophy and what we've been learning over the last 20 years there, and then focus principally on AAV-directed therapies for both SMA and Duchenne. And then at the end, I'm going to touch briefly on a personalized medicine initiative that we and others have been developing, individual drugs for single or small numbers of patients with unique variants in neurogenetic or monogenic diseases. So let's start with SMA, spinal muscular atrophy. It's broken down artificially into 3 types: a severe type 1, as exemplified by this baby. It's about 2/3 of all the infants born with this phenotype. They never sit, they never roll over, and untreated, only about 30% reach their 2nd birthday, and they die of pulmonary disease and infections. Then there's an intermediate form, which is about 1/4 of the patient population, and they sit, but they never stand independently or walk, and they lose typically the sitting ability over time. And then there's a infrequent group called type 3, where they do attain walking, but over half of these children lose ambulation by their 10th birthday. So these are progressive neurodegenerative diseases. And the neuropathology was identified in the late 19th century by Verdnig and then Hoffman. And you can see the abnormal nerve roots, the paucity of motor neurons in the ventral horn of the spinal cord. And the point here is that when we think about SMA, we think of it as a motor neuron disease. That's what we're targeting with our treatments. But if you look at the pathology more completely, and this is a study I did when we were at CHOP, there's pathology in other cells, in dorsal root ganglia, motor cortex, thalamus. And now that we're targeting just the motor neurons, really, are we starting to see some of these other phenotypes starting to emerge? And in fact, we are concerned about the cognitive development in these babies with type 1, even though that we're treating them early. They're doing well from a motor phenotype, but we need to look at them more comprehensively. Is there going to be a sensory component to this that's emerging? And are the dorsal root ganglia particularly vulnerable? Another topic I'll get to in a moment. The second point is that it's not just a neurodegenerative disorder. If you look at the muscle biopsies in the babies with the type 1 most severe form, there's actually an arrest of muscle development. So there seems to be a combination of neurodevelopmental arrest that perhaps we can rescue, as opposed to the more advanced disease seen on the right-hand panel, where there's typical neurogenic atrophy, as you might see also in ALS or other advanced neurodegenerative diseases, where maybe the prospect for rescue and recovery of function is less because we're dealing with a different part of the process. And in addition, we've learned that the neuromuscular junction is an important part of the neuroaxis to focus on, and that's shown on the neuropathology on the left with these immature neuromuscular junctions in the SMA baby, Lindsay Murray's work going back 15 years. And also clinically, we can see that on repetitive stimulation if we do that in a baby. So we're starting to focus on when we use these treatments, what part of the neuron are we really helping? Is it at the cell body? Is it in the axon? Is it the neuromuscular junction? So there's still a lot to learn here from these emerging treatments. So just very quickly, SMA, there's the primary gene, the SMN1, survival motor neuron 1 gene, and then there's a homolog that's not quite identical. One of the 5 nucleotide differences is a 840C to T change, and it's at the +3 site in the 7th exon. So it does not cause a change in the amino acid. So it's a synonymous variant, but it does affect splicing efficiency. And about 90% of the time, it excludes that exon 7 in the SMN2 gene. But about 10% of the time, it includes it. So the rest of the gene is identical. So what does that mean? Okay, you have the SMN1 gene on the right. It has a full-length transcript. And then the SMN2 gene on the left, you can see only about 10% of the transcripts include exon 7. And as such, there's only a trickle of the protein that's derived from SMN2 as compared to SMN1. So it's enough protein to keep these babies alive. It's not embryologically lethal as it is in other species that don't have the SMN2 gene, but it's not enough to promote normal function. Okay. So there are different genetic modifiers that have been identified. I'm not going to go into these today. They're biomarkers that we use both clinically and in clinical trials to help us understand the variability in the phenotype. So turning now to the strategies for these gene-targeted treatments for SMA. So here's a baby with SMA. It's missing a functional copy of the SMN1 gene, right? And it has this 90-10 balance of the SMN2 gene. So one strategy is you replace the SMN1 gene, a gene replacement therapy. And that's exactly what's happened with a commercially available drug now called onasemagene apapervavac. And I'll go into that in a moment. And it's really a remarkable drug and it works well. But there are 2 other drugs that focus on the SMN2 gene to modulate the splicing and to promote further inclusion of exon 7. and to try to restore more of a 50-50 balance such that you make more of the protein from the SMN2 gene. And remember that the full-length protein from SMN2 is identical to that from SMN1. So you're not dealing with you're not introducing a new or different type protein. You're just trying to ramp it up. So I'm going to go through the 3 different drugs that have been FDA approved for SMA. And I'm going to start with an antisense oligonucleotide called nusinersen. And this is the first drug that was developed and FDA approved. And it modulates the splicing of SMN2. Okay. And there are 2 categories of ASOs, right? There's the MOEs, okay, 2nd generation MOEs. And then there's which is a 5-carbon ribose ring. And then there's a separate category called morpholinos, which is based on a 6-carbon morpholino ring. Now, the 2 MOEs work really well for neurologic diseases, but they don't get into muscle. So you're not going to see me talking about MOEs for muscular dystrophy. You're going to hear me talk about morpholinos, which do get into muscle. Okay, so it's given intrathecally, it's been well tolerated, and this is how it works. This is a nice little schema from Frank Bennett at Ionis that he shared with me. So the drug does not work on the primary change, that C to T change that I mentioned. What it's doing is it's a backdoor approach. So what it's trying to do is look at this intron-exon junction between it right here, and it's trying to figure out if we can displace the HNRMP A1 and A2, then we can allow the U1 SNRMP to bind, and it promotes inclusion of exon 7 into the mature transcript. So this works at the pre-messenger RNA level. So here's what it looks like. Boom. This 18-mer, 18 nucleotide segment is nusinersen, as represented on the right. It displaced the HNRMPs, it allowed binding, and then boom, it allows inclusion of exon 7, and you generate full-length protein. Okay, so conceptually, that's what it does, and there's actually proof to show that each of these steps actually is correct. Okay, so yes. Yeah, I don't know. I can exit out right here, right now. Okay, thanks for that. Boy, I have a lot of power here. I didn't know. Okay. Okay, so I want to give you a little clinical context. This is not really a clinically focused meeting, but I want to share with you, well, what does this drug do? How transformative is it? Okay, so here's an early phase 2 proof of concept study. It improves survival. And then we did these motor function scales, and you can see these squiggly lines representing individual spaghetti plots of the patients in this study. And to our surprise, they actually improved. We didn't expect to see improvement for this fatal progressive disease. We expected that it would stabilize babies, and that would be considered a win, but they actually improved. So we had to rethink the whole paradigm of what these drugs can do in some situations. So remember, I talked about the neurodevelopmental arrest, and maybe we can unlock that and rescue it. So here's this type 1 baby. This is a little, and he has his own website now, you'll see in a minute. So this is Cameron and he was treated at 6 weeks of age, 7 weeks of age. You can see he's almost paralyzed. He's not moving, and he's panting. And this is the Kaplan-Meier curve of what his expected survival would be without treatment. And here he is about a year later after he's received several doses. And to my surprise, well, he rolls over, but I clicked too fast. And then here he's sitting. So remember, these babies never roll, they never sit. Plus, he's developing a very important skill, as you can see here, which we didn't capture in the clinical trial. But so he's cognitively seems to be doing pretty well, but you can see he has a G-tube button. He's not normal. But boy, is he doing well. And then here he is more recently. Okay. So, yeah, I mean, boy, he's not walking normally. But the point is, there's a sustained benefit. He's 9 years old, and he's still making gains. So, and he's going to school, and you can see on the right, he's an associate goalie. He's scuba diving with his dad. He's doing stuff despite impairment, but he's doing okay. Now, here's another baby that was treated pre-symptomatically. So after we got FDA approval for the first drug, we went to the NIH and Health and Human Services, and they approved putting SMA on the newborn screening panel. And that's been about 5 years ago. And now 49 out of 50 states in the United States are screening for SMA. So most of the babies are being picked up pre-symptomatically or very early symptomatically. Okay, so, and here he is sitting, he's playing, he's reluctantly walking. Come on, here he goes. Okay, and then there's a little girl ready to go to work or school on the right. Okay, so what did we learn from this? Well, we learned that the black and red lines here represent symptomatic babies treated after symptom onset, and you can see the slow, steady improvement. It seems to have a good durability of effect. And the two blue lines represent the babies who were treated with newborn screening. And it looks like they're actually topping out. Well, there's maybe a lack of further benefit, but they've reached a ceiling effect on this score. We never expected them to get up this high on this motor scale. But you can also see that the babies that had 2 copies of the SMN2 gene, that backup gene, do really well, but not quite as well as those with 3 copies. So it seems that the number of copies is a very strong predictor of how you do. And we knew that from the early natural history studies, but it's even further borne out as we look at even early treatment. So we know early treatment makes a difference as opposed to waiting till they're symptomatic, but we also know that the genotype is important in predicting how they do. So we learned a lot of lessons here. We learned that there's an excellent safety profile. There are over 11,000 babies treated internationally with this, good durability. But we also learned that it's not a cure. So there are actually ongoing studies trying to do a next generation ASO. We're trying to do a higher dose, because the first dose that was approved was not necessarily the optimal dose. It was a dose that worked, and the company with the FDA decided, let's get it out and help as many kids as we can. Now they're trying to optimize it by doing a dose escalation study. Okay, so now I want to turn to gene therapy for SMA. So this is a single intravenous administration of an adeno-associated virus type 9 vector, and it includes the SMN1 cDNA. Okay, so the cDNA, the whole thing can be packaged into the AAV, unlike Duchenne, which I'll talk about in a minute, okay? Now, the dosing here is 1.1 e to the 14th or 10 to the 14th vector genomes per kilogram. And I'm going to be using the same e to the x a lot in the next few slides. Okay. So this is a very good opportunity to look at gene therapy because motor neurons are post-mitotic cells. The idea is, could this be a, quote, one and done? You give it once, you get the cDNA into these motor neurons, and it just establishes its own little factory as an episome in the nucleus of these cells. Okay, and that in fact seems to be what it's doing. And now this particular drug was approved on the basis of a study with 12 patients. Well, actually 3 low dose, and that's a whole different ethical issue because you can't redose these patients. They develop an immune response. So how do you figure on the low dose still has to be an effective dose or else it's not ethical to do it, right? But how do you define that low dose, those 3? And then these are 12 at a higher dose. And it was such a spectacular result that the FDA approved it really on the basis of these small number of patients. And now there are a lot of requirements for what are called post-marketing real-world evidence registries to show that it really works in a broader population of patients. And there have been studies now to show that there's a sustained effect at 5 to 7 years, because the question remains with all these drugs, what's the durability of the effect? So far, it looks really good. It doesn't seem to be wearing off. Now, it might be a different situation in Duchenne where you're treating muscle cells that are still actively dividing. But here, these post-mitotic motor neurons, maybe it's a more optimal situation. And there's also a pre-symptomatic study that also had spectacular results. But as I'm going to show you in a minute, this is limited to young infants. And I'll explain why. But let me just spend a minute on what does the vector actually look like. So this is a cartoon from Novartis, the pharmaceutical company that makes this drug. So here's the SMN1 gene, the cDNA in blue. Okay. And I want to point out that there's ubiquitous chicken beta actin promoter and a CMV enhancer. And that's really important. And it's very different from the Duchenne studies where we were trying to use more muscle-directed, muscle-specific promoters. And when we start thinking about side effects and off-target, this is really an important topic. Okay. The other thing is that this was designed to be self-complementary, meaning that instead of giving a single-stranded RNA, this is double-stranded. It's already, when it gets into the nucleus, it's ready to go. Okay, so there's not a latency to it start to generate the RNA and then the protein. So it may have a quicker effect, but there are certain risks with double-stranded versus single-stranded, which I'm not going to go into today, but it's an important point. Uh-oh. Okay, now we go. All right, so let's go back to the pre-symptomatic study. And I mentioned with the ASO nusinersen that the babies with 3 copies all did well. We see this also with the gene therapy shown here on the right-hand panel. They're all in the gray zone, which is for typically developing children. But those babies with 2 copies, even if they're treated pre-symptomatically in the first 6 weeks of life, you can see that about half of them are doing really well. They're going up and up and up, but they're lagging a little bit behind that of typically developing children. So even treating them in the first few days or weeks of life doesn't seem to be a cure. And we don't know what this means later on. Are they going to start to regress? Are they going to continue to lag when they're 5 and 10 and 15 years old? We don't know yet, but there's still a lot to learn here. So there are several issues here that create some confusion. The FDA approved this drug, onisimagene abapiravac, for children up to 2 years of age, independent of their genotype. The EMA looked at the data differently and said, we're going to approve it for all children up to 21 kilos in weight, independent of their age. So we're getting very different experiences from Europe and the US because of the patients that can be covered or treated. The second point is that the payer policies, the health insurers, the Medicaids in Europe, the NICE in the UK, different payers have different policies. So in the UK, they're only covering symptomatic babies with 2 copies, who are type 1 with 2 copies of SMN2. So it's leaving out a lot. Now that's changing rapidly, but that was the first approval. Okay, so even though the EMA said, you can cover everyone up to 21 kilos, the payers are being very restrictive and basing it on the data from the clinical trials until there's more robust real-world experience. Now, safety. This is still evolving. There clearly are some safety issues that need to be identified. And this came from the non-clinical data, first in mice, where they tried to identify what's the maximum tolerable and safe dose. And it was done in mice, but not in non-human primates, which might be an important distinction. And it was identified as 1e14 vector genomes per kilo, where they saw some cardiac thrombi. And this created actually a problem because the FDA required that we do all sorts of cardiac monitoring in the children. And that's burdensome. We're doing a lot of blood work and this and that. Fortunately, we're not seeing any signals in the children. But you can see how once a door has been opened, it's hard to close that door. Okay. Thrombotic microangiopathy, or TMA, occurs in about 1%. This is a complement-mediated event that occurs typically in the first week. And I'll talk more about that later. And then there's liver inflammation, a transaminitis, which in some cases has led to liver, and that's very common. About 2/3 have a spike in their AST, ALT, GGT. A small number actually go into liver failure, and that's characterized by increase in bilirubin and general shutdown of the liver. And then of those, a small number have died. So there have been a handful of deaths attributable to liver failure, and in part because they didn't seem to have good standard of care to support these babies in liver failure. So the point here is you shouldn't be treating with gene therapy if you can't treat the potential consequences. You need to be at a center of excellence that knows how to handle immune-mediated responses, such as here at UCLA. The other point is I want to return to that idea that there's the Chica beta CBA and the CMV enhancer. It's ubiquitous. So there were 3 autopsies, and they looked at the transduction of different cells, and there was really good transduction of motor neurons. But in liver, it ranged from 300 to 1,000-fold higher than motor neurons. So think of the liver as really the main target here. We want it to be the motor neuron, but it's really the liver. Okay. So there's some other issues. If there are pre-existing antibodies to this AAV serotype, which occurs in about 13% of newborns, because they get it passively from the mother, what do? If they want the gene therapy, you can't do it because there are limits to their titers that you have to respect. So for that, typically what we're doing is we're treating either with nusinersen or risdiplam, one of the other 2 drugs. And then once the titers fall, which could take a few months, then we can flip over and we can switch to the gene therapy. That's creating havoc as well with the payers. They don't like one expensive drug, let alone 2. Okay. There's also an issue of, well, there's 3 drugs. I'll show you the 3rd one in a minute. All of them work really well, but are all of the motor neurons transduced? Probably not. They're given different ways, intravenously, intrathecal with nusinersen, then it has to get passively absorbed into the motor neurons of the brainstem and spinal cord. Okay. And then intravenously with the AAV, and it crosses the blood-brain barrier. That's one of the nice features of AAV9, is it crosses blood-brain barrier in children. But does it get all the motor neurons that need to be, do they get transduced? So we don't know that. So the question is, well, what about adding a second drug? And maybe there's a synergy there. So those are some topics that are now being looked at. And what's the durability and the safety, et cetera. Okay, so I want to turn now to an important topic of DRG toxicity. And this, I'm going to spend a few minutes on this because I think it's particularly important. So this was raised first by the Jim Wilson lab at Penn. Okay, in this paper in Human Gene Therapy in 2018. So they gave an AAV, as you can see here on the right, and they to 3 non-human primates and 3 piglets. Okay, and there was liver failure in one of the monkeys, DRG changes in all 3, and of the 3 piglets, there was a dorsal root ganglia ganglionitis, also with some clinical signs and pathology. But they did not identify any T-cell response to the capsid or the transgene. So they didn't really know what that meant. So moving forward, now the same lab, led by Juliette Hordeau, did this meta-analysis of 256 non-human primates with all sorts of different AAVs, not just for SMA or Duchenne, but they just lumped them all together and said, if you give it intrathecally, 83% had some signs of DRG toxin. And if it was given intravenously, it was 32%. And it was evident, not right away, but typically in 1 to 5 months. And then that effect, that inflammatory response seemed to wane, but did not necessarily go away completely. Okay, and none of these were clinically evident in the group that they studied. And importantly, it seemed to be independent of the capsids, or the promoter, or the transgene, or the age or the sex of those animals. So that created some further discussion in the community. And then there's this important paper by Megan Van Alstyne in the Livio Pellizzoni's lab at Columbia and with George Mentis. Okay, so what they did is they took an AAV9 with the SMN1 cDNA but it had a different promoter, and that may be really important here. They did a GUS-B promoter, not the chicken beta actin and CMV. And they studied it in the Delta 7 mouse model, which is the standard severe mouse model developed by Arthur Burgess at Ohio State. And they gave it a single ICV injection on day P0, day of birth. And it showed that the improvement in survival, improvement in function that had been demonstrated previously by others and was used as support for the clinical program. What they then did is watched these mice for several months. And at about 4 months, they saw a decline in motor function. Okay, so that's the last thing you want, right? Okay, so then they pathologically, when they sacrificed the animals, they saw both loss of dorsal root ganglia neurons and motor neuron loss and inflammation. Okay. Furthermore, they saw that there was some aggregation of the SMN protein in the cytoplasm. And then they showed that that affected, because SMN works as part of a complex that regulates splicing of other genes. So it showed that there was splicing dysregulation because of this presumably aggregation of SMN protein. And there were a lot of transcriptional changes that promoted neuroinflammation and innate immune response like toll-like receptors. So this paper created a firestorm, and some of my colleagues said, I'm not using this drug, this gene therapy drug in babies, till we figure this out, because we're treating them, and we don't know what we're doing here. So there's been a lot of work done since this paper. There's a second study by Arthur Burgess that used the exact drug on a gene epiperfect. He did not replicate these same findings. So he thinks the difference is due to the promoter. But that hasn't been published yet, and we'll see. Now, this is another important paper. This was done by Novartis, the company that makes the drug. So you got to kind of keep that in mind. So they did a study in part because it was required by the FDA. Okay. So they did a 12-month intrathecal study in non-human primates, okay, with a 6-week interim analysis. And they did it at 3 doses, a therapeutic dose, and then 2.5 times that, and then twice that. So 1.2, 3, and 6 e to the 13th vector genomes. Okay. So here's what they found. So well, there we go. So one of the biomarkers we look at is a neurofilament level, because it's a measure of axonal damage. It's non-specific, but when you're dealing with a neurologic disease, the last thing you want to see is your neurofilament level going up. And this is not the first time this has been shown, but the controls are in blue, and then this is the low in the middle and the high dose of the gene, and you can see the neurofilament levels go up acutely, and then it comes back down, but it doesn't necessarily come back down to baseline. So the question is the gene therapy, when given intrathecally, causing an inflammatory response? And does that mean anything down the road? So then they looked pathologically, and yeah, well, there's all this inflammation. You can see here the neurons don't look happy, and these neurons that are undergoing some distress are the ones that seem to have a higher amount of the vector that's been transduced. And this is immunohistochemistry on the right. So there seems to be an association between high transduction, which you can see how it varies in the brown speckles, and the neurotoxicity and the inflammation. So in other words, not all the cells are being transduced at the same level. So it's something we have to keep in mind. Okay, so then they did another study with prednisone or rituximab or everolimus. It didn't seem to change anything. At least in this study, there wasn't any benefit of the immunosuppressive treatment. So shown here is all this all this inflammation here at 13 weeks, and a lot of it subsided by 52 weeks, but notice the gliosis that's going on here. Okay. So then finally, they did a study that the FDA required to add on with and without prednisone. Does prednisone make any difference? And no, it didn't. So this to me is an important study because it raises more questions than it answers. But, you know, and this is, the other thing is that because the drug is approved by the FDA intravenously, only up to age 2 in the US, we're trying to see how can we treat more children? What happens about children 2 years of age, 15 years of age? Well, that's where this fixed dose intrathecally, it's not per kilo, it's a fixed dose. So this is creating quite a bit of concern about how safe is it to give intrathecal gene therapy. And there may be more of a class consideration. This may not be specific just to intrathecal for SMA. It may be in other conditions as well. Okay. Third drug I'm not going to dwell on is a small molecule drug. And it also works at modulating splicing, and it works well. The only reason I'm showing this baby is I treated her prenatally. So when I mentioned that treating them even right after birth doesn't seem to be a cure, the question was, could you treat them prenatally? So we got a single patient IND, and we gave the drug to the mother. It crosses it's an oral drug, it crosses the placenta, got to the baby, and we did a whole bunch of studies during and following pregnancy. And if time allows, I'm happy to go through that later, but that may open up a new door to sort of move the needle a little further, even prenatally. Okay, so let's go on to dystrophinopathies. So there are a few points I want to emphasize here. So here's the dystrophin gene, 79 exons. Okay, and this is the way they look on this cartoon. And the thing that I want to highlight is that we've learned that there seems to be some immune concerns for those individuals that have mutations between exon 1 and 17, this early part. Okay, and you'll notice that there are these hinge regions, 1, 2, 3, and 4. 1, 2, 3, 4. Okay, but it's this area, this early part, that seems to be particularly important for increasing risk. Okay. The point on this busy slide is to say there are different types of mutations, from deletions to duplications to single nucleotide variants. And each of these may have different immunogenic properties. So they're not all the same. And we can go into that later, but you have to look at the individual mutation in the category to try to understand this better. So there was the first of the trials was an oral drug read-through for nonsense mutations. It has very limited benefit. It's never been approved by the FDA. It was approved by the EMA for Europe, and then that was rescinded because of a lack of apparent clinical benefit. And this is one of those where the biomarkers seem to suggest benefit, but clinically, maybe not so much. So I'm not going to spend time on it further. The next treatment are back to our friends, the antisense oligonucleotides. And as I mentioned, this is morpholino-based because it gets into muscle. And about 80% of Duchenne patients are exon skippable. And those are the 4 of the 5 currently FDA-approved drugs. But they only apply to a small proportion of patients that have mutations that are amenable to skipping. So for exon 51, it's 13% from this pie chart on the left, et cetera. And as it turns out, the improvement is kind of meager. You can't visually see it. Again, it's been more on a biomarker basis. Yes, it increases dystrophin expression, but not a lot. Okay. And there seems to be some variation. There is a next generation of ASOs that's being developed. Better muscle penetration, higher expression, and less frequent administration are the goals. And this is just an example of one study that I'm involved in by a company called Dyne. So, and I'm not here to promote it, I'm just using it as an example. But if you look at the top right panel, you see that there's a high percentage of dystrophin positive fibers at 4 weeks and at 8 weeks and even at 12 weeks. So this is suggesting that, in fact, there is much better tissue penetration than with the first generation, and that there's better durability. So there's some question now about, okay, for patients that are treated with gene therapy, should we be co-treating them with an exon skipping ASO? Because maybe they're complementary. So this is still an active topic. Turning now to gene therapy studies for DMD, and I've listed 5 of the active ones. Now, Sarepta is the one that has an approved drug, and I put it in here. This is the trade name, Elevidys. All the others are the investigational names. Okay, and I've listed the different vectors, and you can see that they vary. RH74, AV9, AV8. The promoters differ. The doses are pretty similar. These are all around 2 × 14 vector genomes per kilo, and they're given IV. Okay. Some of them include the NOS site, the nitric, some don't. Some include the different hinges, which may or may not be important. So I'm just pointing out the variability here. But what we've learned from some of the side effects, the serious side effects, is that we need to exclude some patients that have particular exon deletions because they are immunogenic in and of themselves. They already have been primed to react against a novel epitope. And in fact, there's been 1 death in the Pfizer study as well. So, but there've been a lot of discussion, and so I just want to finish up focusing on some of the immune response issues to AAV. So they're the early ones that are complement mediated, thrombotic microangiopathy, myositis, myocarditis. There are later ones which are from acquired immunity, both T and B cell response. The paper I showed here is from a meeting report summary that is quite good in Journal of Neurologic Disorders. So in addition to safety, though, these immune issues can reduce transduction, and they may reduce the transgene expression and durability as well. So it goes beyond safety. There are a ton of issues. Pre-existing antibody titer, are they binding antibodies? On an ELISA, are they neutralizing? How high is the titer to make it a problem? What's the cross-reactivity between, say, AAV9, AAV8? And that depends on the clade that they're in, and that's in the upper right-hand side. So if they have a high antibody to AAV8 and you're giving them AAV9, is that a problem? Some of that still needs to be worked out. The capsid serotypes, the total dose, and in particular, what's the percentage of the full capsids versus the partial and empty capsids? Because you're giving something that's not going to benefit them with an empty capsid, but it's still immunogenic. So how can we improve the manufacturing to make a higher percentage of full capsids? The inclusion of how many CPG, unmethylated CPG motifs, is also important. So what's being included in the transcript? Okay, the immune responses, as I mentioned, there's an early innate, a later acquired, but we're focusing a lot on these CRIM-negative patients, those that have null mutations. They've never seen this protein before that's now being expressed, and so it's a foreign protein to them, as opposed to those patients that did have, saw a little bit of it or enough of a similar protein that they're not freaking out when they see this new protein. So there's another paper from Melissa Spencer's group that just came out, and it's really kind of interesting and important. And it looks at some of the innate and adaptive immune responses in a mouse model that are dual treated, and then 4 weeks later treated again. And there's a lot in this paper, and I'd encourage you to read it. Unfortunately, I'm running out of time soon. But the take-home messages are listed here, that seems to be AAV IgG complexes that are generated specifically after the second administration. So when we think about redosing patients, what are some of the risks, and can we do that? And that these complexes seem to activate the complement pathway. Monocytes are important. They seem to generate these pro-inflammatory cytokines and chemokines. So it really raises a lot of other questions. And you can see from the upper right-hand panel, those that have a Cas9 component here, such as in a CRISPR scenario, you can see have a much higher risk of activation of TLR9. So a lot to be considered. There are a lot of immune mitigation strategies, including prednisone, using eculizumab for complement-mediated conditions. What about using rituximab to reduce the B-cell population, sirolimus through the mTOR inhibition pathway and IL-2 activation for T and B cells? All of this is being tried. And at the bottom, I've just given a couple examples. There's one going back 6 years to Barry Burns' work with Canavan's disease, and he pre-treated with rituximab and then sirolimus. And then a current study in Duchenne, Regenexx Bio, is using sirolimus and eculizumab, sort of more prophylactically rather than reactively. And there are many other scenarios out there. I want to finish up with talking about some alternate approaches to gene therapy. First is Kevin Flanagan's work at Nationwide Children's Hospital, and he's looking at the patients that have a duplication of exon 2. And he's using a AAV9 with a U7 snRNA to sort of skip over exon 2 because the rest of the transcript's normal. So it could potentially result in a wild-type dystrophin construct. Or maybe it'll skip over both copies of exon 2, which wouldn't be so bad. But that's a different approach. Another is dual AAV constructs, which is shown in the right-hand panel. The total cDNA size of the native wild-type cDNA is 11 kb. And you can only put in about 4.5 kb into an AAV. But if you have two of them, well, you can get about 9. So you can get a closer to full-length transcript. So some people are looking at these dual, and then they anneal each other, and they form one nice big happy dystrophin RNA. So that's being looked at. And a third one, which hasn't been publicly announced, but there's a drug company looking at treating muscle by intrathecal delivery. And you might say, that's interesting. And the idea there is, okay, you can give a lower dose intrathecally. It comes back out systemically. There's a better safety profile, and it's still going to get into muscle just as well as with intravenous. So that remains to be seen, but there's sort of that backdoor approach. Okay. Final word on CRISPR. One patient was treated and he died. And that's highlighted in this paper in New England Journal. And it was a very well-meaning, very sad situation. The drug company was set up to treat one patient, and it was his brother. And he died. And it raises ethical issues. It raised a lot of medical issues, scientific issues. But I credit them for putting together a pretty thorough report and putting it out there so that we can all learn from this. But it has kind of put a chill on the whole CRISPR idea for DMD for the moment, but we'll move forward. I'm not going to talk about X-linked myotubular myopathy. I'm assuming Perry Shea's already done that. The paper on this is going to come out in 2 weeks, I'm told, so you'll be able to read about it. Final word is ultra-rare diseases. There are a lot of efforts out there. Some of them are listed here, looking at ASOs on the left, upper, and then AAV gene therapy for N of 1 patients or N of few. And there's an effort at the NIH called the Bespoke Gene Therapy Project, shown here, in the cartoon is from the paper by PJ Brooks, that outlines how they're trying to set up a platform design where you make an AAV, and the only thing you're changing is the cDNA. And they seem to be getting some approval from the FDA to sort of try this carefully. Okay, so all of these are in clinical development, but it looks like for these ultra-rare diseases, these are patients who are orphaned because they're not commercially viable. There aren't enough of them for a company to develop the drug and make any return on their investment. So these are being done by philanthropic groups. So we're just putting our toe in the water at St. Jude on this as well, and other places are. So in conclusion, gene-targeted therapies can be effective and transformative, as I think I've tried to convince you. There are all these other considerations that need to be taken into account. There are all these challenges, but forward we march. So with that, I'll stop. And these are some of my acknowledgements. And I hope, we have time for a few questions. Thank you so much for your attention. It was really delightful to be here and speak with you today.
And we have a little bit of time for questions. Thank you. And you, yes, exactly. If people wanted to come to the microphone to ask questions, that'd be
Do we have any
my
questions?
best, or we can run microphones around. And in theory, I could see questions here online.
In theory. All right, well, I'll turn it over to you. All right, who's first? Come on, don't be shy. Well, I apologize for going so fast, but I wanted to really get through a fair amount of information and sort of whet your interest in some of these topics. No, you can't leave. Sorry, not today.
So what's the longest that a child has been post gene therapy now in your observations of the
Yeah, so I was on the DSMB for the first patients that Jude and Endowed treated. And that was in 2014.
9 years out.
Yeah.
And how's that cohort doing?
They're doing well. They are still making, now they were all symptomatic. They weren't pre-symptomatic, but they are doing well. The part of the challenge is no one of the three drugs seems to be head and shoulders above the others with regards to efficacy or durability. The safest one seems to be nusinersen, the ASO. And you say, well, you're giving these by repeated spinal taps to these little babies, but they tolerate it remarkably well. It seems the drug itself, the ASO, seems to be very well tolerated. We're just not seeing problems. There's, with gene therapy, probably 98% do well after you get through that hump of the first 3 months. Okay, with all the immune response. But then there's this concern about what about late findings, these DRG findings and issues and the durability of the effect. And so we don't know. And the risdiplam, the oral drug, also works really well. And that's probably best as a global drug because it's oral, you don't have to freeze it at -80 and you can send it to Africa and wherever you're trying to treat patients. But it has a very narrow therapeutic window, and the company knows that. So it's not the most effective dose, it's the safest dose that has the best effect. They had to kind of thread the needle because that drug has potential, a lot of off-target side effects. It affects the G cycle, the cell cycle. So at higher doses, it has retinal toxicity, renal toxicity. So they know that. So they're going for the safest dose that will help the most patients. So that has its own issues, and that's why these post-marketing real-world evidence registries are so important to capture safety mainly. And it's a requirement in Europe for getting approval that you have to have these registries because a drug that's approved on 12 patients doesn't tell you a whole lot about the safety profile. Yeah, you had a question?
Oh, yeah. I was wondering, were there any, I guess,
do you see any side effects on the prenatal dosing with the oral drug?
We didn't. N of one. It's one patient that we treated. She's now a year old. So, and the journal said, come back to us when she's a year old with safety data. So to your point, they wanted to know, are there any side effects that emerge? So we haven't seen that so far. And the FDA, this was kind of an interesting issue because there were a lot of ethical issues. You're treating two patients, you're treating a mother who doesn't have the disease, you're treating the patient, but the FDA was very helpful in guiding us through that. And now they're saying, well, are you going to do more? Because there've been a lot of questions from other families. I get a couple inquiries a month. And it's okay, now but the FDA is saying, now you have to do a real study, a real clinical trial. Because these single patient INDs are almost compassionate use. And we tried to squeeze as much data as we could out of it to identify the safety profile, biomarkers, all that. And so far, everything was favorable, but it's only one patient.
Can I ask you, just amongst those who've gotten gene therapy or type 1, ultimately, or what proportion of those end up being also on the exon inclusion therapies, either the oral drug or nusinersen later?
Okay. So the question is more broadly rephrased as the parents are very happy that they've gotten a treatment for their child and their child's surviving and improving, but they also come into the clinic and say, well, what can you do for me today? What else can you do? What about adding a second drug? How do you know? There's no data because the studies haven't been done, but can't we just try adding on a second drug that works through a different mechanism? So you've got a gene replacement therapy, you're replacing the SMN1 gene. What about a second drug that modifies SMN2 and increases the SMN expression through a different pathway? And maybe it also reaches different cells because you're giving one intrathecally and you're giving one intravenously, crossing blood-brain barrier, et cetera. So, and that's a very reasonable conjecture, but it's actually hard to answer that. So there are some studies being done, some in mice, and because there is no naturally occurring animal model for SMA. So they're transgenic mice, but we don't have, and there's a sheep model, which is a knockdown sheep model, but there's no non-human primates. So we're kind of limited there. In humans, the drug companies are saying, yeah, well, we can try it, but it's really going to be a safety study because how do you actually measure adding a second drug on? Is it going to change the trajectory markedly? Is that child suddenly going to get up and walk? Well, probably not. Are there biomarkers that we can use to show that, like the neurofilament levels, which is what we use a lot of? Well, if it knocks down the neurofilament level more when you add on a second drug, probably that's good. So we don't know how to answer that question, but it's an important one.
All right. Well, I think we've run out of our time. We give our speaker today final round of applause and thank you.